Namaste everyone, I'm Dr. Ujjwol Risal. I'm a rheumatologist currently working at HAMS Hospital, and I'll be taking you internal medicine lectures. Welcome you all to Paradise Institute. So today I'll be teaching you rheumatoid arthritis. So let's start the session. So I'll be teaching you rheumatoid arthritis today. So the topic for today is rheumatoid arthritis. My handwriting is not that good, so bear with me. So, as we all know, rheumatoid arthritis is a chronic disease, chronic inflammatory disease. So it's an inflammatory disease of the joints, chronic inflammatory disease, and it is an autoimmune disease. It is an autoimmune disease. And it mainly affects the synovial joints. So why I said mainly, because it can affect the other parts of the body as well. For example, it can affect the eyes, it can affect the lungs, it can affect the heart. That's why, so these are known as the extraarticular features of rheumatoid arthritis that we'll be talking about in a few minutes from now. Primarily, it involves the synovial joints. So, regarding the its epidemiology. So, the prevalence of rheumatoid arthritis is around 1%. 1% in the whole world. So that means it affects about 1% of the population. For example, the population of Nepal is 3 crores, so it affects around 3 lakh people in the country. And it mainly affects females, females more than males. So the male to female ratio is 3:1. So so female to male ratio is 3:1. So it affects more in females than males. So female to male ratio is 3:1. And especially it affects women in their 50s. Women in their 50s. So it mainly affects women in their 50s. So this is the epidemiology of the condition. Now we'll talk about the pathophysiology. So we'll talk about the pathophysiology. So how it causes the disease. So regarding the pathophysiology, so the etiology is unknown. So etiology is unknown till now. Etiology is unknown. However, various factors have been implicated in the disease causation. For example, genetic factors. Genetic factor. Mainly HLA-DRB1 gene. HLA-DRB1 gene. That is the most implicated gene in the pathogenesis of the disease. Another is environmental factors. Environmental factors. So various viral infections have been implicated in the disease causation. For example, Epstein-Barr virus, parvovirus, smoking. So it may be related with smoking. So it is more severe in smokers than in non-smokers. So host factors. So many host factors are there. So that could affect the disease causation. So it's the interaction among these factors that causes the disease. And so how it affects the synovium. So first, the synovium is affected in the joints. For example, it's a synovial joint. So this is like the this is the cartilage, hyaline cartilage covering the joint, and this is the synovial lining. So initially the inflammatory cells, they'll attack the synovium, and finally there will be a release of various cytokines, and there's also infiltration of B cells that will eventually give rise to plasma cells, and plasma cells will make antibodies. And then these antibodies, they combine with antigens to form immune complexes. Immune complex. So they form immune complexes, And there's also release of various cytokines like interleukin-1, interleukin-6, IL-6, TNF-alpha, and interferon gamma, INF-gamma. So many cytokines are released. So that causes intense inflammation, and that leads to joint pain, joint swelling. And well, it not only affects the joints, but also affects other systems of the body as well. So it may affect the eye, it may affect the lungs, it may affect the heart. And also there are constitutional symptoms in rheumatoid arthritis that we'll be talking about in the clinical features. So let's talk about the clinical features of rheumatoid arthritis. Clinical features. So it basically affects the joints, okay, primarily the synovial joints. So it is a symmetrical polyarthritis, okay, polyarthritis. So polyarthritis means 5 or more joints are affected. So it's a symmetrical, means both sides of the body are affected symmetrically. So, and it's a polyarthritis, not oligoarthritis, not monoarthritis, it's a polyarthritis. So what are the features of the inflammatory joint pain? So usually patients complain of pain while the extremity or the involved organ is at rest. That means that when the joint is at rest, the pain will be more. At rest, pain will be more. Okay. So when you start moving, for example, after a patient wakes up and starts doing their household chores, the pain subsides. But when they rest, when they go to bed, when they go to sleep, the pain increases in intensity. And there's also associated swelling of the joints, okay? Swelling of the joints. And patients also complain of early morning stiffness. We call it EMS, that is early morning stiffness. And it may last up to 30 minutes or maybe more than 30 minutes, maybe 1 hour, 2 hours. So depending on the severity of the inflammation, early morning stiffness may last many hours also. Okay, so if it is very severe, it may last many hours. So these are the features of inflammatory joint pain. So patients complain of these symptoms, and especially the joints that are affected are mainly the hand joints, okay, mainly the PIP, that is proximal interphalangeal joints, PIP joints, these MCP joints, okay, metacarpophalangeal joints, wrist joints, okay, elbows, shoulders, okay, may affect the cervical spine, okay, and then knees, MTP joints, metatarsophalangeal joints, and IP joints of feet, and also ankle joints, okay. So these are the joints that are mainly affected by rheumatoid arthritis. So rheumatoid arthritis characteristically spares the DIP joints. That is, distal interphalangeal joints are usually spared in rheumatoid arthritis. And also it spares the lumbar spine and thoracic spine, okay, and sacroiliac joints also. So it mainly involves the cervical spine. So apart from joint pain and swelling, patients may also complain of constitutional symptoms. So what are the constitutional symptoms? Okay, constitutional symptoms include fever, malaise, weight loss, fatigue. So these are known as constitutional symptoms, okay? Because of profound systemic inflammation, patients complain of these symptoms. So these are fever, malaise, weight loss, and fatigue. Now we'll be talking about the extra-articular features of rheumatoid arthritis, because rheumatoid arthritis is not a disease of joints only, so it can affect other organs. Most commonly it affects the eyes, okay? Eyes in the form of keratoconjunctivitis, SICA, okay? So these are the extra-articular features, okay? Extra-articular features. So eyes in the form of kerato means cornea, conjunctivitis, okay? Conjunctivitis, SICA means dry, okay? So it means dry eye syndrome. So patients complain of extreme dry eyes, okay? Extremely dry eyes, and they also complain of dry mouth as well. So these are the extra-articular features of rheumatoid arthritis. Also, they may complain of xerostomia. So that is in your extra-articular features of in mouth. But for the time being, let's remember that the extra-articular features mainly involving the eyes are keratoconjunctivitis, SICA. So that is the dry eyes. Okay. Apart from that, it may cause episcleritis. Okay, episcleritis or scleritis. Okay, the difference between episcleritis and scleritis is episcleritis is superficial, it doesn't cause pain. However, scleritis is deep, it causes a deep boring kind of pain, and it is more severe, okay, more serious than episcleritis. Episcleritis is a benign condition. Sometimes it might cause uveitis as well, okay, uveitis. So these are the extra-articular features that you see in eyes. So what about so as I said before, in mouth it might cause dry mouth, okay? So that is also part of the extra-articular features of rheumatoid arthritis. So it might cause dry mouth. What about the lungs or respiratory system? Okay, respiratory system. So most commonly it causes pleural effusion. Okay, most commonly it causes pleural effusion. Okay, or you can even say pleuritis. Okay, pleuritis. So if there is pain along with effusion, we call it pleuritis. If there is no pain, only effusion, that is pleural effusion. And so apart from that, so what about the characteristic of pleural effusion of rheumatoid arthritis? It's usually exudative. Okay, it is exudative with low glucose. Okay, low glucose. Okay, so that is the exudative effusion with low glucose that is characteristically seen in rheumatoid pleural effusion. So apart from that, so it might affect the lung parenchyma. Okay, lung parenchyma. So in the form of interstitial lung disease. Okay, we call it interstitial lung disease or ILD. So ILD can be caused by rheumatoid arthritis. So there are various types of ILDs. I don't want to go into the details of various kinds of ILDs, but just remember that rheumatoid arthritis can cause interstitial lung disease. So what about cardiovascular system? Okay, cardiovascular system. So rheumatoid arthritis can cause most commonly pericarditis, okay, or pericardial effusion. Pericarditis. Well, it is the most common manifestation of rheumatic heart involvement. Okay, pericarditis or pericardial effusion. Okay, and apart from that, it can cause ischemic heart disease. Okay, IHD. It can cause heart failure. Okay, heart failure, ischemic heart disease, conduction abnormalities. Okay. So basically, these are caused by rheumatoid arthritis. Now let's talk about the hematological system involvement. Okay, hematological system involvement. So mainly, it affects the RBCs. Okay, let's talk about hematological system. So most commonly it causes anemia of chronic disease. Okay, AOCD. That is anemia of chronic disease. That is the most common manifestation of rheumatoid arthritis, extra-articular manifestation in hematological system. Okay, anemia of chronic disease. Sometimes it might cause thrombocytosis. Okay, thrombocytosis, but not thrombocytopenia. Okay, thrombocytosis, and sometimes it can cause leukopenia also. Leukopenia. Leukopenia. But so there's a condition called Felty syndrome. Okay, Felty syndrome. Felty syndrome. So it is associated with splenomegaly, neutropenia, and thrombocytopenia. Okay. So it is seen in rheumatoid arthritis. So characterized by splenomegaly, neutropenia, and thrombocytopenia. So that is known as Felty syndrome. So this is the only condition where we see thrombocytopenia. Now let's talk about the skin. Okay, skin. So what it can cause? So we've heard of rheumatoid nodules. Okay, rheumatoid nodules. So rheumatoid nodules may be present in skin. Okay, mainly the extensor aspects of hands. Okay, rheumatoid nodules. So especially in seropositive patients. Okay, seropositive patients means those whose antibodies for rheumatoid factor and anti-CCP are positive. So they may have rheumatoid nodules. So apart from that, there are other skin manifestations, but that is out of the scope of this lesson. So we'll just stick with rheumatoid nodules. And there are other manifestations like in the form of neurological involvement, renal involvement, but we are not going to discuss that. And one thing I forgot to mention is the Kaplan syndrome. Kaplan syndrome. Kaplan syndrome is a condition associated with pneumoconiosis plus RA. So it is known as Kaplan syndrome. So they mostly ask in MCQs. So what is Kaplan syndrome? So it's a pneumoconiosis plus rheumatoid arthritis is Kaplan syndrome. So after this, let's talk about the investigations. Okay, so how do you investigate patients with RA? Investigations. So most of the time, patients have anemia. Okay, anemia. If we do CBC, they have anemia. Usually, anemia of chronic disease. Okay, AOCD, anemia of chronic disease. They may have thrombocytosis. Okay, thrombocytosis, and what about the inflammatory markers? Okay, inflammatory markers are usually raised in these patients. So CRP, C-reactive protein, and ESR. ESR are high in these patients. Okay, C-reactive protein and ESR are high in these patients. What about the antibodies? So what is a rheumatoid factor? So they ask in MCQs what rheumatoid factor is. So we call it RF as well. The rheumatoid factor is, so most of the people say RA factor. That is not correct. Okay? We should say RF, not RA factor. RF is the correct terminology for it. And so it is an IgM against the Fc portion of IgG. Okay, IgG. So what is a rheumatoid factor? Rheumatoid factor is IgM against Fc portion of IgG. That is rheumatoid factor. So it is seen in around 70% of patients of RA. So that's what we call sensitivity. So sensitivity of our rheumatoid factor is 70%. That means in patients with RA, so it is positive in 70% of people. Okay, but sometimes it may be falsely positive in conditions like hepatitis B, hepatitis C, cryoglobulinemia, infective endocarditis. Even in normal population also it may be positive. But specifically, it is not. But it is usually positive in rheumatoid arthritis patients in 70% of cases. Okay. So what about anti-CCP? So anti-cyclic citrullinated peptide. Okay. cyclic citrulinated peptide. So anti-CCP is positive in around 70% of cases. Okay, so same sensitivity. So it is also positive in 70% of cases, but the difference is specificity is very high. So that means it is positive in. So if it is positive, so there's a 90% chance, more than 90% chance that it is RA. So we call it specificity. So sensitivity is the same as rheumatoid factor, but specificity is more than 90%. Okay, more than 90% specificity with anti-CCP. Now we'll be talking about the imaging. Okay, imaging. So most commonly we do plain radiography, that is X-ray. Okay, X-ray of hands. So in advanced cases there might be erosions. Okay, erosions in joint spaces. Erosions. So there might be periarticular osteopenia. Okay, periarticular osteopenia. So this is in early disease. Periarticular osteopenia is early disease, whereas erosions are late, okay, late manifestations. And joint space narrowing might be seen in late cases. Okay, joint space narrowing. So these are the imaging features. So apart from X-rays, we can do USG of hands and other joints, as well as MRI, but we don't usually do it in real practice, especially in this country, but we usually go for the X-rays of hands. Now, how do we diagnose rheumatoid arthritis? How do we diagnose it? So it's basically clinical history from the patient as well as the investigations. So diagnosis. So one is clinical, another is lab. Okay, so clinical, patient must have symmetric polyarthritis. Okay, polyarthritis. So if patient has such symptoms, we tend to think patient has probably RA, but there are other differentials as well. But we tend to think RA when patient presents with symmetric polyarthritis. And then in labs, if patient has raised inflammatory markers like raised CRP and ESR, and if patient has positive rheumatoid factor and positive anti-CCP, so diagnosis is almost confirmed. Okay, positive anti-CCP, especially when anti-CCP is positive, because it has high specificity. So diagnosis is almost always rheumatoid arthritis, and so based on these features, we diagnose rheumatoid arthritis. There's a classification criteria also. Classification criteria. So this is the ACR-ULAR. Okay, ACR-ULAR criteria that was devised in 2010. This is not for clinical diagnosis. This is only for research purposes. Okay, there are so many sets of criteria, and each criterion is given individual points, but we don't use it in clinical practice for diagnosis of patients. We use our clinical judgment and lab investigations for the diagnosis. However, it might be helpful in research. It might be helpful for research purposes and in difficult cases where it's very difficult to diagnose this condition. Now we'll discuss the treatment of this treatment of rheumatoid arthritis. Okay. So treatment can be divided into two arms. Okay, one is for the short-term control. Okay, short-term control of the disease activity, and another is for the long-term. Okay, long-term. For short-term control of the disease, we usually give, so that suppresses the inflammation. For the short-term control means it suppresses the inflammation and pain, and for that we give NSAIDs, okay, NSAIDs, that is non-steroidal anti-inflammatory drugs. So you can give any one of them, okay, ibuprofen or naproxen or indomethacin and so on. Okay, so these are the NSAIDs that we can use for the control of pain and inflammation. And another is the steroid. Okay, steroid. So steroid can be given either IV or IM or oral or even intraarticular. Okay, intraarticular. So in steroid, we mainly for oral we mainly use prednisolone. Okay, prednisolone. IV for IV, we may use methylprednisolone or hydrocortisone, and for intraarticular, we might use hydrocortisone or methylprednisolone or triamcinolone. Mainly, we use methylprednisolone and triamcinolone for intraarticular injections, especially when patient has involvement of one joint, severe inflammation in one joint. We use intraarticular steroid. Okay. So, so that is for the short-term control, because we cannot give NSAIDs for a long time, and neither can we give steroids for a long time because of their toxicities. However, we have to use treatment for the long-term control of rheumatoid arthritis, and they are known as DMARDs. Okay, DMARDs, that is directly acting anti-rheumatic drugs. Okay, directly acting anti-rheumatic drugs. So for the long-term control, we use directly acting anti-rheumatic drugs, and these DMARDs, they slow the progression of disease. Okay, they slow the progression of disease. So basically, they control the disease. Okay, so the short-term treatment, we suppress the inflammation. For the long-term control, we have to slow we have to halt the progression of the disease. So what are the DMARDs we know? So DMARDs that we know. So one is most commonly we use methotrexate. Okay, methotrexate, leflunomide, sulfasalazine, okay, sulfasalazine, hydroxychloroquine, azathioprine, and so on. Okay, so most commonly we use methotrexate, leflunomide, sulfasalazine, hydroxychloroquine. So basically these are the DMARDs that we use for rheumatoid arthritis. However, DMARDs take some time to work, around 1.5 months to 3 months. So during that time, we have to bridge the therapy with steroid or other agents that control the pain and inflammation. So, the toxicity of methotrexate, leflunomide, well, it might be, methotrexate might cause bone marrow suppression, it might cause lung fibrosis, it might cause liver damage, especially elevation of liver enzymes. So in that case, we have to monitor these parameters frequently. Okay. Similar is the case with leflunomide. It might cause lung toxicity, it might cause liver toxicity, it might cause bone marrow suppression. So we have to frequently monitor these parameters. Similarly, sulfasalazine has similar side effects. And hydroxychloroquine, basically it can cause a retinal damage on prolonged usage. So we have to do proper eye evaluation at baseline and even after starting hydroxychloroquine. Azathioprine has similar side effect profile with methotrexate and leflunomide. So with the treatment, most of the patients go into remission or they improve, and if they don't improve, we can use other agents that can control disease activity. So they are known as the biologicals. Okay, biologicals. So they include TNF inhibitors. Okay, TNF, tumor necrosis factor inhibitors. Okay, inhibitors. So we can use certolizumab. So it might be a little difficult for you. Okay. So adalimumab. So golimumab. So etanercept. Infliximab. So these are the TNF inhibitors. So you can remember with the formulas HI. Okay. That's how I remember it. Certolizumab, adalimumab, golimumab, etanercept, infliximab. However, use of TNF inhibitors, well, it is associated with toxicity. Usually, it mainly causes serious infections, and it might even cause reactivation of TB. So long-term usage may lead to malignancy as well, and it might cause exacerbation of heart failure. And they are very expensive, so we don't use them frequently, especially in our country. And there are other biologicals like interleukin-6 inhibitor. We've been using it in COVID as well, so that is tocilizumab. And nowadays we're using Janus kinase inhibitors, okay, JAK inhibitors as they are known as, JAK inhibitors, especially tofacitinib, okay, tofacitinib. So it is an oral drug, and it is available in Nepal as well, where we're using it for severe joint pain, which is not responding to conventional DMARDs. We can use tofacitinib. So that is all about the treatment of rheumatoid arthritis. And sometimes if patients don't get treated, they might go into complications, okay? Especially when they don't get treated. So for example, they may get develop various deformities like. So let's talk about the complications of RA, okay? Complications. So in complications, they might develop deformities, okay? Various deformities. So I'll just demonstrate, okay? So one is the swan neck deformity. Swan neck deformity means, so this is your PIP, this is your DIP. So there will be hyperextension of your PIP joint and flexion of your DIP joint. So this is known as the swan neck deformity. So that is one of the complications of RA. Another is the boutonniere deformity. Boutonniere means there's just the opposite of swan neck. So there's flexion of the PIP and there's hyperextension of the DIP. So this is known as boutonniere deformity. And there's also Z deformity of the thumb. So the thumb looks like a Z. So that is also one of the deformities seen in RA. And there might be ulnar deviation of the fingers. Okay? Fingers will deviate towards the ulna, and radial deviation of the wrist. So this wrist will deviate towards the radius. So radial deviation of the wrist. So you can remember R for R, okay? Radial deviation of the wrist. And there might be other deformities of the toes as well. And similarly, other complications involving the extra-articular manifestations, for example, interstitial lung disease, ischemic heart disease, so that might be seen, and even vasculitis might be seen. Okay. So I think that's all about RA for now. So we'll be doing more lectures in times to come. So I'd like to end my lecture today. Thank you so much for listening. See you around.